Welcome to Forward Physio, the show that gives you high-quality information about injury and rehabilitation, performance, and health. I am Noah Mandel, and I'm a physical therapist in Toronto, Canada. The purpose of this podcast is to give you educational content, not medical advice. So if you are dealing with a health-related concern, please take it up with your healthcare professional. If you enjoyed the podcast, I would really appreciate it if you'd be willing to leave a review. It takes 2 seconds, and you would be doing your part in helping the podcast grow so that we could provide this information to more and more people. Thank you very much for listening, and I hope you enjoy. Hello everyone, welcome back. Today I had a conversation with Wilfried Simon. If you follow him on Instagram, he is also known as the Spine Physio. I'll give you a guess as to what it is that we talk about today. Will is a physical therapist and educator who was born in Paris but is now working in Belgium. He is a specialist in spinal conditions and back pain. Compared to all other body parts, I feel like back pain has the most misconceptions and myths surrounding it. So I had Will on to provide some clarity on this topic and debunk some myths, to provide some helpful suggestions, and to bring some awareness to a bunch of different conditions related to the back. I think this is a good podcast for both clinicians, but also the layperson. So if you know anyone who is struggling with back pain, this could be a good podcast to send them. About halfway through the podcast, I realized that my mic was on the wrong setting. So at first, the audio is a little bit strange, but I did my best editing it. So bear with me. It does get better as the podcast goes on. Luckily, Will's audio is perfect. And of course, he does the majority of the talking. Without further ado, I bring to you my conversation with Will. All right. I am here with Wilfried Simon. Will, before we begin and talk about all things related to back pain, do you mind giving us a little bit of an introduction?
Yes, of course. I'm Wilfried. I come from France, but I live actually in Belgium for now 8 years. And I'm a physiotherapist. I'm an osteopath as well. And I'm specialized in spine treatment. So ankles, I don't give a... I won't say it.
You can if you want.
I don't give a fuck. I don't find it interesting. I love the spine, the neck, and most importantly, the low back. It's fascinating. And that's why I turn my practice into this direction.
Got it. When did you change your practice to become more specialized towards the spine?
The change happened probably 2 years after I was a physiotherapist. And then with the osteopathy, it became more centered toward this direction because it's very linked to the spine, too much in a weird way. But that's another topic. And then because in the practice, we see actually a lot of back issues. We are confronted a lot to these issues. And so I wanted to be much better at it. So when you deep dive into a topic, you want to be better, and that's how it came with more my specialty.
Mm-hmm. So in Belgium, what's the main difference between an osteopath and a physiotherapist? And in practice, do you use one title or the other? Are you technically operating as a physio? How does that work?
So the first difference is probably on paper. If someone comes with a prescription, it's under physiotherapy. If it's not under a prescription, it's under osteopathy. So that result that the price is not the same, and the refunding or the reimbursement is not the same as well. So it's cheaper to go to a physiotherapist than to an osteopath. And also because I work at the hospital, I am conventioned, so I cannot increase my physiotherapy prices. It's the lowest you can find. So actually it's quite fantastic for a patient, because in my practice I cannot separate both of them. It's impossible. I tried to, but it's impossible because I can take the best part of it, of both of them. So for the patient, they have the best of it. at a cheap price if it's physiotherapy. Price is important for the people. If it's too expensive, uh, they cannot follow a few sessions. Not everybody has the money to pay the sessions.
Of course, yeah. What is the best of physiotherapy and maybe the worst, and vice versa? What's the best and the worst for osteopathy?
With physiotherapy, I would say exercises. I never learned exercises with osteopathy. It doesn't turn around exercises. So that's the best part. And it's a very important part, actually. With the osteopathy, I would say I develop a kind of touch with the patient. So very manual therapy, feeling more confident touching the patient, manipulations, and also just simple mobilizations. Did it come with the osteopathy? Did it come with the years of practice, actually? But I love touching patients. I couldn't do my job without touching patients. That's one of the most important things for me. It depends how you use it, of course, but we need this contact. We are in the healthcare and we are physiotherapists or osteopaths. These kind of things, that's the first, like shaking your hands, shaking the hand of the patient as the first thing you do. You kind of settle the thing. Do you have a good contact with this person? Do you feel a good energy kind of way? And this is how it starts.
Right. Yeah, it's not just important from a therapeutic or diagnostic standpoint. It's also
No,
important from just developing a relationship with the person, right?
it's kind of related with the therapeutic, of course.
Yes. So your specialization, as you said, is in back pain. And on Instagram, first off, if someone listening to this doesn't follow you and they're a clinician, go follow the Spine Physio on Instagram so that you could learn a ton. You have incredibly informative graphics and posts. So first off, thank you for the work that you do there. And just seeing all of the stuff that you have posted online has really made me want to talk to you, because I think you just be an excellent resource for people to understand back pain, because it is one of probably the most, I guess, areas where there's the most myths about them and the most misinformation in probably all of physiotherapy or healthcare. So let's really dive into, I guess, back pain and all of the myths that surround it and how we should go about thinking about it. And one of the most common myths, or at least ideas around back pain, is how important posture is for preventing back pain. So how important is the alignment of somebody's spine or their posture when it comes to preventing the onset of back pain?
So I want to start with the fact that the onset of low back pain, so the first time that a patient has a low back pain, it's barely inevitable. Nearly everybody will have in his life low back pain. 84%, according to studies. Let's do 100% if you want, okay? Let's be generous. So we cannot avoid it. So we are trying to talk about something that it's unavoidable, sorry. So why are we so obsessed with a perfect posture, with a perfect alignment, if we basically know that we cannot avoid it? There is like an obsession about it. In our culture, we have to be straight, we have to show the pecs, we have to be taller. Who said this to you the first time? I think it's like me, it was your mother who probably said, you have to stay straight when you're at school, otherwise you're gonna have a slouch back and you're gonna have some problems with your back. This is the first thing you hear. Your mother, the parents, okay?
I guess it's
So,
something all over the world.
I,
Every mother says this, I guess, because I have
of
the
course,
same experience.
of course, and you cannot imagine how much patience I have who say, "Yeah, I've been told I have to sit straight, I have to be straight because my parents told me so." When we are kids, we can be easily brainwashed positively, but also negatively. So the impact of the words and who said the words is very important. A mother, we trust our mother. Okay, a doctor, we trust our doctor. If it's just the neighbor, we don't care actually. It depends who's your neighbor.
Yeah.
But posture and alignment, there is nothing that proves that it helps to, I won't say for preventing the first onset of low back pain, but eventually for recurrence, it doesn't help. Actually, it's been proven that if you try to be too straight, it's going to be worse. And first, that's what I tell to the patients. The more you think about your back, the more chance you have to, you will have back pain actually. We shouldn't feel the back. We shouldn't think about the back if it's okay. Do you think about your toes right now? No, we don't care because everything is okay. Why is it such a big deal with the back? It's just a
Yeah.
back.
It's a very, very good point. There is such an obsession about it. And I find there's also this obsession about just preventing pain and immediately thinking that it's something like it's the end of the world when we have back pain. It can be very, very painful for people, don't get me wrong,
It's,
but
yeah.
we have this idea that something is, I think, terribly wrong
Mhm.
when we do have back pain. So I think in a lot of people's minds we have to prevent it,
Yeah.
right?
Yeah, exactly. The disability is also not the same when the pain is very acute. Um, very very acute. You see those patients who are very locked. They cannot move. They cannot going straight. If you twist your ankle, for example, you can always find a way to still move. You can use your what's the name, the canes,
Mm-hmm. Yeah,
to
canes, walkers.
yeah, walkers
Yeah.
to support you. You can use one leg eventually. You can find a way easier than with the back, and that's where we have to try to help the patients, is to find a way to still move even if it's barely not possible. And it's not so simple for patients regarding the back, like my example with the ankle, which is very much easier actually. You don't put your weight on your ankle and it's done. But with your back, you have to support yourself. How can you do without? And that's our job, to increase the awareness of the patient of what they can do, what they cannot do eventually. But that's our goal, to guide the patient as much as possible. It could be with the hands, it could be with some exercises, it could be with reassurance, the words and the touch actually.
Mm-hmm. Yeah, the point about just getting back to moving is interesting because when it comes to an ankle sprain, we're okay with people limping, right?
Yes.
It's something that we understand as sort of just this natural protective way to keep us moving and without re-aggravating or making the injury any worse. When it comes to back pain, sometimes the more comfortable posture is one that we tend to demonize, right?
Hmm.
This slouching posture.
Hmm.
Or for other people, the more comfortable posture may be one that's more upright. So would you say when you're helping guide people towards moving again, whether it's with reassurance or with exercise, does the advice there, does it include that, it's okay to slouch a little bit right now, or it's important for you to be upright for that matter?
It really depends of the context. For some people, I won't say that slouch. I try to find a better position, which is more comfortable for the patient. But you see in some patients that slouching, it doesn't go well. It creates very much pain, eventually some neurological symptoms. And that's not the goal, to make the life of a patient a nightmare just because you think straight back is better, is not good, and slouch is better. We have to find a balance between both, and always depending on the context.
Right. So for some people, it's okay to give that advice that, they should maybe be upright.
Yeah,
And for
yes,
others, the opposite. But
of
it's
course,
not
of
so much
course. In
about
some moments,
presenting.
it's about, not about the position. It's about the movement. We want as much as possible movement, of course. So, of course, if your patient stays 2 hours straight, upright, it won't be good. It's exhausting. We want to spare some energy, and by slouching, you would spare more energy. But in a position that you maintain for too long time, it's not going to be good as well. Slouch as well.
Move if you can.
Of course, of course.
Right. Yeah. So I guess the idea there is that it's not really possible to prevent the onset of back pain, at least with postural interventions. But it is okay to tell someone to change their posture after they are experiencing back pain to help them sort of moderate their symptoms a little bit.
Yes.
Okay.
Yeah. Yep.
Is there anything we can do at all to prevent it? Has there been people or groups of people that we see are less likely to experience back pain than others? Is that 84% just a really wide net over the entire population, or is it do we find some people are less prone to back pain?
People who are more prone to back pain, it's sedentary people. So it rejoins, again, the fact that if you don't move enough, it's not good for your body. Actually, you need to move enough. So sedentary is not a good point. There are some type of work, like if you do a very physical job, of course, you are using your back more. It's not all about the mechanical thing. It's also the stress during the job, but some occupational job as well. But if we want to prevent as much as possible the low back pain, we have to be confident about using the back pain. So the psychology behind it, we have to use the back and do not fear using the back. So training the back muscles is also a good thing, actually. And it would be my two most important points. So the confidence and training the back, actually. Maybe I could add also the comorbidities like alcohol, smoking. Maybe the thing that we don't think in the first place, but smoking is not a good thing. When you look at how the impact it have on the arteries, how it reduce the arteries and the blood flow, the nutrition for the tissues is very important as well. So this is something important, yeah.
Yeah, I find that's an area that commonly is confusing for people, how our whole health can sometimes make pain more likely to occur in one area. And it's not just the low back. Smoking can increase the risk of you having tendon-related issues, perhaps for similar reasons. But yeah, I think that's a very good point as well, to be mindful of just someone's total health outside of just what they're doing with their back mechanically, right? We're very complex organisms, and our experience with pain depends on a lot more than just, how we use a certain body part, although it is definitely an important piece of the puzzle.
Of course. The lifestyle is very important. And we shouldn't point the patient on what he doesn't do well. For example, you don't eat so very well, then it's a big problem. We have to discuss about it with the patient to do not put too much emphasis on this. But we have to take into account the lifestyle of the patient. Of course, it could increase the sensitivity of the body, and so increase the pain that the patient can feel.
Right. And if we go back to what our mothers used to say about us, where they used to yell at us about our posture, for most people, it probably didn't work. And it's a similar thing with nutrition, right? You can't just tell people to eat better. Behavior change is hard. It's really complex. So, I mean, that's a really good point that you bring up, that we have to actually speak with the person instead of talk at them.
Yes, of course. Also, what I feel with the patient is, they have in their mind, like, who are you to tell me about what I should do? We are not nutritionists. We are not a doctor. We are just a physiotherapist. We are a movement specialist, if we want. So who the fuck are you? We can say it's crazy, a podcast. Who the fuck are you? But who are we to talk about what people should do. So we shouldn't place ourselves like we are the boss, we know everything better than you, and we tell you what you have to do. It's a communication that we have to build, like a trust, like a friendship, where we like we share things. It's totally different. We share, we take informations, we can rebound on the informations of the patient, but we shouldn't try to put our informations in the head of the patient like this. No, it's a communication. It's like walking hand in hand with the patient and not
Yeah.
pulling someone.
Well said. Very well said. So another really interesting area that also surprises patients sometimes is how common asymptomatic findings can be with people. How often people can have something like arthritis or a disc herniation on imaging, but not have any pain at all. And it's an area that's confusing for me. I'm hoping that you can help me out here. So how important is, I guess, structural integrity when it comes to back pain? Why are some disc herniations painful and some aren't? And how common is it for people to have asymptomatic findings compared to an actual finding on imaging that correlates with their pain? And if that was way too many questions at once, you can
Yes.
just answer one at a time and I'll repeat them. So I guess to start off there, how important is structural integrity when it comes to back pain? Does imaging findings always correlate with pain, if not in a moment or later down on the road?
I don't know if I'm going to answer to your question directly, but structure is important. It's a fact. It's a part of the pain. We cannot avoid it. We cannot say only that structure is not important. It's only in the head of the patient. It doesn't fit. But the thing is, when we look on imaging, and we can see some changes which are related to the pain of the patient or some serious pathology, it's not a big part of low back pain patients. We'll say it's around 10%, all included, like serious pathology, neurological deficit, where we can compare those symptoms and signs with imaging findings. So it's not so much. One patient on 10, it happens, I would say. But what was your question?
Yeah, no, it was how important is just the structure. So what you're saying is that sometimes people don't have something that is, I guess, seriously structurally wrong with their back, but they still have pain.
Okay, so we are talking about the non-specific low back pain, actually. In this case, where is the structure important when we have to deal with someone where we don't know actually what's going on?
Right. So, in that case, how would you explain to a patient why they're in pain if we can't see anything on the image?
So first, the patient comes to us with the physiotherapy, with the prescription. Most of the time, they don't come with imaging for my part, because it's the first step. First step is conservative treatment. We'll see what it gives, and if it doesn't work, then we have to eventually make an imaging. So the first step is we don't have so much clues through the imaging, but it's not so important because most of the time it's not related to something that we can assess with a test, with a specific test. So the thing is, what can we tell the patient if it's the case? How can we reassure the patient that first, we don't really know which structure is implied, and eventually, if we know, should we tell it? Because we can assume it has more likelihood to be a facet, for example. It could be more a disc. It's a question of likelihood, but not a certainty. Should we tell the patient? I most of the time don't tell the patient. I don't want to take risk with this. it's not important. I try to make a diversion for the patient. I try to put more attention on something else than on what's going on precisely on the back. Otherwise, I could make a thought. Maybe I could say a word that would be good for me actually, but wouldn't be good for him. So I don't take the risk. I try to don't take the risk. I don't know
So
if
your
it was clear.
concern there is,
I
sorry,
would
go ahead.
say I would say I'm like a politic. I try to turn as much as possible around the question of the patient without answering it, if you know what I mean.
Yeah, no, I do. So why is it that you would avoid telling somebody something like that? What's your concern there?
That's a good question. That's a very good question. Because it has been seen that if you put too much emphasis on the structure, then the patient would also think nearly only at the structure. But the structure represents a small part of what the pain is. The pain is very wide. The structure is important. It takes a part, sorry, it's not important, it takes a part. But it's a small part of the puzzle. And do we have to take this piece of puzzle and to make it big, or do we have to take it and lay it very small and emphasize the rest of the puzzle? And that's the goal, I think. To don't have the same size of puzzle pieces, but actually it's different size, different shapes, and depending on the patient, you make a puzzle with different type of puzzle pieces.
Right,
It's
based
clear,
off of how, based off their story and their presentation, you do
of
your
course.
best to determine the size of different pieces. Just so patients and clinicians are aware, what are these other puzzle pieces? What are some examples besides the structure of their actual back?
That's a very good question. Um, Always good questions with you, Noah.
Thank you, Will.
You have the anatomical structure. That's what we said just right now. You have all the other piece of the puzzles, like the beliefs of the patients. Is it good beliefs? Is it bad beliefs who could have a negative impact on the patient? What I ask for the patient is, for example, what do you think is the cause of your back pain? And if he says it's a posture, we are in a kind of discussion about is it good or not good? Is it a good posture? Is it not a good posture? Is it something which makes the pain worse? Of is it something which makes that the pain stays because there is this belief about something, and actually it can brings more tension in the body of the patient, increase the pain sensation, and it won't go better with the time. So the beliefs of the patient is very important. Also, all those emotions. When a patient has pain, he cannot do what he wants. He cannot lift a kid, for example, because I'm a father, so I give a kid example. That's typical. Um, he cannot work, for example, with his dog. I don't know, some activities that he cannot do. So there is emotions behind it. The pain produce emotions like frustration, like um, anger, fear as well. If the patient can
Frustration.
frustration, like I said, the fear. I fear I will break my back if I bend my back, if I use my back. So all those emotions are not helping the patients to feel better. It increases the pain as well. It's all these kind of things. The lifestyle, like we said, smoking, alcohol, sleep, social contact. When you have pain and you don't dare to go to the next position to see a beautiful photography on a wall, because you know if you stay more than 10 minutes standing, then you're going to have back pain. So you don't do it. You condition yourself to do not do it. You prepare yourself to don't do it because you know already you're going to have pain. So all these kind of things we have to take into account with the patient, we have to ask, we have to be curious, genuinely curious. We have to get into a discussion to know those feelings, the thoughts and the feelings.
Hey physios, I know that we all know how expensive continuing education courses can be. What if you had the chance to learn from some of the brightest minds in the industry from the comfort of your own home, all at the fraction of the cost of those weekend courses? This is where Masterclass by Physio Network comes in. Imagine having front row access to the world's leading experts breaking down complex topics into digestible module-based video courses. It's basically like Netflix for physios, and it gives you the option to learn about a ton of different topics. If you're interested in a particular area, the chances are the Physio Network already has a masterclass on it, or they're working on one right now. Masterclass is your ticket to staying relevant, informed, and delivering the best care possible to your patients. Click the link in the show notes and use the discount code NOAH10 at checkout to get an exclusive 10% off on Masterclass. Don't miss this opportunity to elevate your expertise. If you're still unsure, test it out with a 7-day free trial. You're going to love it. It's so important to have these long discussions with patients, and I find that maybe in the world of physiotherapy, 20 years ago, we're coming from a place where we're trying to figure out structurally what is wrong with the person. Are they out of alignment? Is this muscle too tight? Are they moving in this wrong way? And to neglect having that conversation about their fear of not going to an art gallery, or not going to walk their dog, or not spending time playing with their kids, and how that's affected them over the years, to avoid conversations like that. It's kind of scary, what we're leaving on the table. And it's such an important thing to discuss with the patient, to just understand at least that they're working with someone who cares about them and who understands them. And you can also tailor your advice a little bit more specifically to them when they have these complaints, right?
I remember when I'm just 35. I'm not so old, but there is a part of maturity we are getting with the years. Some people are more better at this. You seems to be a guy to be very fluent when you talk. That's what I perceive from you. But I'm a kind of guy which can be a little bit shy, doesn't dare to dive too deep into some topics. But because I got older, because I feel I'm more mature, because I have a family as well, so all these kind of things outside of our practice make us better as well for the practice. Simon Sinek is a fantastic guy with the why. And what I do with the patients is most of the time I ask why. And if you ask like 3, 4, 5 times just why, they feel at the end that I don't know actually. Because in the beginning, they don't know what to say. If you just ask, why do you have pain? I feel I've been there because someone told me that it's not good to bend my back. Okay. But why why deeply do you feel it's not good to bend your back? And that's in this way that you can go deeper and deeper, always asking the why of the patients. Why do you have pain? Why do you feel this way? And you have more explanation than just a word.
That's a really good strategy. I think a lot of new clinicians, when they're going through their subjective interview and they're asking a patient all these questions, a lot of the time in their mind, they have to check all of these different questions off of the list. It's almost like a checklist. So a patient might say, "Oh, I think it's bad to bend your back." And some maybe new graduates will say, "Oh, okay." And then they'll write that down on their notepad.
Yes.
And then they'll ask the next question instead
Better
of
with the
taking
sleep.
that as
With sleep, it's more better. Do you sleep well? No. Do you have pain at night? Yes. And it stops there. That's it.
right.
But we can go deeper with this. Why do you sleep badly? So you have pain, but why do you have pain at night, for example? And then it depends, maybe a position, a feeling. why do you feel so stressed at the moment? Why do you feel that you're you're frustrated, for example, and not only the emotion, but why are you frustrated? And this way you take very much more information from the patient, and you can go out of this checklist. Actually, this checklist is not so important. If you discuss with the patient, you have a big picture of the patient. That's the most important. Big picture about disability, a big picture of frustration and very bad emotions like this. Um, that's a big picture you want to know. If is it very mechanical, for example, then the mechanic would be eventually more dominant. Is it just I have pain when I lay in my bed at night? I feel okay the whole day, but when I lay in my bed, I feel pain. So you think, what's the problem actually? You don't use your back. It's just when you rest, you feel it. So why do you have pain in your back if you don't use it? And that's where you can enter in discussion about, do you feel you avoid feeling the pain during the day? Do you feel you have such a busy day that you don't take the time to feel the pain? And you have this type of patients. We talk about endurance or avoidance coping. So people
Hmm.
who try to do not think about the pain at all, and people who put too much attention to it, for example. That's very important. It's just the checklist is not so important, actually. You want the checklist of the big things, and the rest, not so much. If you have a good discussion with the patient, maybe with experience as well, it could help to have more, you're more precise in reading the patient. That's it. And the use of questionnaires could help as well to have a structure, to have some things that you have on paper, of course, but you can do it after. Second session, why not? Why not?
Right. As long as you rule out things that are very serious in the first session, right?
Of course, you have to protect yourself first if there is a big problem, and you have to protect the patient as well. Because if there is something very bad and the patient, I don't know how it is in Canada, maybe it's like in America, people want to, I don't know, to put you to the lower, I don't know, but you have to protect yourself first. If there is a problem and you didn't do the right things, first you will feel guilty, but also the patient could put a complaint against you. So protect yourself and protect the patient.
Yes, I don't think in Canada there's as many patients that want to sue as maybe in the States, but I don't know the statistics on that. But it is important to not just protect the patient, of course, but also to protect yourself. So on that note, what are those very serious things, and how common are they when it comes to back pain?
So you have the fractures, you have the cancer, you have the infections, you have, I would put in it, the axial spondyloarthritis. It's not like a serious thing that you have to refer directly to the GP or emergency, but the treatment is totally different. Um, um, and also the last one, it would be the Cauda-Eckner syndrome. So when you have a very big neurological deficit, uh, it's not for you. It's not for us. There is maybe a surgical way that's important to be aware of. We shouldn't demonize surgery. It's important in some type of patients. Fractures, it will be totally different on how you would give some exercises. I would say, for example, if you mobilize and manipulate, that wouldn't be a nice thing. Good thing to manipulate on a fracture. So you want to protect yourself as well if something happens, and to protect the patient, of course. Infections are also very important. Most of the time, it happens after a surgery, for example, a back surgery. So if you see a patient post-operative, there could be a risk of infection. Something important with infection, with the fever, it doesn't happen so often, actually, the fever with an infection. And the patient, when they have pain, they take painkillers. And those painkillers, they could decrease the fever of the patient. I don't have a term
Oh,
when who
really?
has yes.
Oh, wow.
So for example, you have a patient with an infection, and this patient thinks I just have back pain, so I would take some painkillers. Okay, It would decrease the fever as well. So when you ask the question for the patient, do you have any fever? No, I don't think so. But it could be the case actually.
Oh wow. I
Fever is
that's
not.
I did not know that the painkillers would reduce the fever.
Mhm.
Wow. Sorry, what were you gonna say?
So these type of things, the fracture, like I said, the Kodai syndrome, you have to be aware of neurological deficits, some bowel issues, bladder issues, of course, numbness around all those genitals. And that's it. It's very minimal. It doesn't happen so much, but we have to be aware that it can happen. Normally, if the patient comes with a prescription, the GP should have done his job. So, in as a second line clinician, we shouldn't see it so much. I don't see it so much actually. It happens very rarely.
Right. In Canada, you can see a physiotherapist before ever seeing a doctor, so you could be the first point of contact.
Indeed,
So
indeed.
if there's any Canadian physiotherapists or other physios where you're the first point of contact, definitely have to keep those things in mind. For
Yes.
something like a fracture, I think a lot of the time when people hear fractures, they think about being put in a cast and immobilizing. And that's not always the case with a vertebral fracture. So, how would you go about screening for one? And how would you offer advice towards a person with maybe a vertebral fracture?
So you have to be aware that if there is a traumatic onset in a flexion position, there is more likelihood that there is a vertebral fracture. Typical jumping from the roof, jumping in a swimming pool, it happens. Okay. The age, of course, an old people old person, sorry, and especially an old woman who has osteoporosis, it makes the bone density weaker, so there is more likelihood. So if you have an old woman of 70 years, for example, who complains about back pain, low back pain, and I want to rebound on it, thoracic pain, because it's not always where you have the pain that there is an issue. It could be a little bit higher that you have the pain or lower, depending on the site of the fracture. So some thoracic pain, low back pain, and traumatic onset are not old women with osteoporosis. So you ask this patient, do you have any osteoporosis, or do you have family history of osteoporosis, or did you break in the past your spine? There is more likelihood that it's going to be the case again.
Okay.
In any doubts, it's always better to refer. It's always better to refer. And I think, so do I sometimes, we don't want to see the worst in the patient. We mostly think it's not a big deal, it's not a problem, but it could always happen. And when we have this suspicion there is an issue, it's better to refer, to do not take the risk. If it's okay, then the patient will be always thankful to come back and to say, you did your job, there is no problem, so now we can take actions.
Right. Right. Okay.
It's difficult
And
to say to a patient, I think it's not for me today. It's difficult
yeah, it
when we
is.
know
But
that 90% of the cases it's not a big deal. I mean, structurally.
right. So there's a figure there to keep in mind. And right, 90% of the time, it isn't something that is very, very serious. Most of the time, it's non-specific low back pain where there isn't something that structurally is very wrong with the person.
Yes, indeed.
What's the typical care pathway for someone with a vertebral fracture? Is there one that is very, very common? Does it differ from patient to patient?
I have to say, I do not have so much experience with vertebral fracture. The one I had to treat, it was a conservative treatment, also post-operative as well, but not so much in my practice. So I couldn't give you so much information about it.
Okay.
I don't want to
Well,
take risk with it.
Thank you for your honesty. Appreciate it.
Yes, we have to be honest sometimes.
Of course. So let's say
Sometimes.
we've ruled it. Right. Let's say we've ruled out everything that's very, very serious, and we think we're dealing with somebody with, non-specific low back pain, or there's just, a relative or a friend with low back pain. Is there advice that we can give to the population? So let's put you at the in the World Health Organization. Okay. You have a seat at the table now, and they ask you, Will, what can we tell the world when they have low back pain and it's not serious? Is there advice that we could give to people? Or would you give them a hard time saying it depends?
That's funny because I wanted to say not what should we say to patient, but what would we do to do not have to come to this point actually.
Hmm.
I always had in my mind that if we can bring some better information at school with children, for example, it would be a first thing to put good things in the head of the kids, like the mother did, but not especially in a good way. To put positive things in the head of kids, so after they don't have those doubts, of probably less doubts, about using the back and how they could avoid back pain. You know what I mean?
Yeah, no, it's a very good point. I think that would solve a lot of issues if we started earlier on in life, because so many of the issues we face with back pain are from poor beliefs, right?
Yes. And the social media, for example, um, if you just open your TV, you would see some advertising about some corset to wear, also some things for the neck, and all this kind of way to be straighter. You can hear from clinicians as well some things that we shouldn't say and which are quite bad for the patient. So if we could brainwashed positively a kid, it would be better.
Hmm.
I don't know, it's
Yes.
very ethical to do it, but it would be a kind of good way, I think.
Yeah. So how would you brainwash the kid? What are some things that you would tell them?
If you have back pain, don't panic. It's just back pain. Okay, don't panic. Find the right balance between movement and rest. Stay very positive. Pain is very intense. Okay, but it will also decrease very fast. Um, the brain did its job. He wanted to protect you. He will protect you if it happens, but it's not linked to the to any damage you could have. It's more like he wants to protect you as much as possible, like a very good friend. He did his job; it's very good. But now you have to tell him that it's okay. You did your job. Now I'm doing my part. My part is moving and getting more confidence in using the back again.
Well said. I spoke to Ben Cormack one time, and he put it in a way very similar to what you just said, where back pain can be seriously painful, but it's often not medically serious.
Mhm.
And I think that's a good point as well. So the advice there, I really like the overprotective friend analogy. Do you use that with patients?
A lot. This friend thing, a lot, especially with chronic pain. They have a lot of pain. They feel like they want to take their back. They want to put it away and do not deal with it again. So it's not a solution. You cannot cut your back and put it away. So I tell them that for the moment, it is an enemy to you. You don't want to, you want to confront him. You do not want to have contact with him. But actually, the pain is a friend. Without pain, we would die. For example, the classical example, if for this type of patients, of people, sorry, who cannot feel the pain, if they put their hand on the fire, they won't feel it. The hand burns. Okay, the hand is a fantastic protector. But when the pain is too dominant, the protector becomes an enemy. And we have to make the switch for the patient. And that's why we guide the patient to find the right movement, the right um, thinking around the pain, that the pain begins to be a friend again.
I love it. And I find I would bet that a lot of the time it opens up sometimes a funny conversation for people
We
when
have to
they
have
would say, what kind of friend is this as well?
then then they start to complain about their friends, but
Right.
it's not my problem.
Let's get back to your back.
Yes, yes.
One other thing I wanted to talk to you about was another area of back pain where there's a lot of myths and misunderstandings about it, and that's sciatica.
Mhm.
I have only been a clinician for just over a year now, but the amount of people who come in and tell me that they were diagnosed with sciatica or they went on Google and Google told them that they have sciatica and they don't have any symptoms similar to it, or it's truly astonishing. And I don't know if it's the same in Belgium, where a lot of people think that they have sciatica and they don't. But have you found that to be the case?
Yes, of course, of course. Like in France, where I worked, sciatica for a patient, it means pain in the leg, but it could be very different type of things. Pain in the leg doesn't mean anything. It could be a lot of things. Um, that's a problem with sciatica. It has been very much used. It's an easy word as well, just one word. Actually, now we shouldn't say sciatica. We should use the word spinal related leg pain. It's a little bit more complicated. With the patient, I still use the word sciatica depending on the patient, because why would you make something more difficult to understand for the patient? You can describe differently, but I still use this word with the patient. But sciatica, the problem is a bit of everything. Is it a radiculopathy? Is it radicular pain? Is it somatic referred pain, actually? Is it coming from the back or is it coming from the glute? Is it the piriformis? It's a bit of everything. And that's why the spinal related leg pain, it describes that it's a pain. It's not about a radiculopathy, so it's not about a loss of function. It's about a gain of function. It's spinal related, so it doesn't come from the glute. It comes from the back and radicular pain and painful. So you can find in the studies a lot of different words to express sciatica for me. And what I could see is just pain, pain on the sciatic nerve. That's it. Coming from the low back.
Right. So
And
what would
most of
that
the
look?
and most of the cases it comes from a disc herniation. 80% of the cases it comes from the herniation. 80-90%.
What would the other 10 to 20% be there?
For the sciatica coming from the back,
Yes.
it
Yep.
could be an infection, it could be a cancer, so like the serious thing we talked about before. It could be this type of things, for example.
Okay.
A lot of things,
So
just
what?
something irritating the nerve in the spinal area.
Right. What would it present like clinically? What would the typical patient look like with spinal related leg pain? And how would you differentiate that between a somatic referred pain?
What I do is I use a questionnaire. So the first you ask the patient, which type of pain do you have? So you are waiting for some features of nerve pain that you can confirm with the questionnaire. I usually use the DN4. It's a French questionnaire because maybe because I'm French, I don't know actually. But I find it very clear, very short, easy to ask, easy to understand. That's why I use these questionnaires. It basically use again the nerve features, the nerve terms to describe the nerve pain. And depending on the score you have, it would be a neuropathic pain or it wouldn't be a neuropathic pain. Okay, you want to have this kind of words like electricity, um, um, along the leg, but going very far along the line, that the patient can trace the pain. It's not always the case, but most of the time he can say it's there. I can follow the line. Um, you have tingling, pins and needles, burning as well, painful cold sensation. Sometimes I ask, did you already hit your elbow against a chair? You feel this sensation? Do you feel approximately the same in your leg? And that's where they can compare this kind of sensation and really nerve pain in the leg.
Mm-hmm.
There is also this kind of paroxysmal pain, something that you do a movement and like, "Whoa, I feel the pain in my back and in my leg." That would be more nerve related.
I see.
But
Is it
I
possible to
must,
have?
yeah, tell me.
Sorry, I was going to ask: is it possible to have pain that is related to the nerve without those burning, electrical, numb, and tingling sensations? So if you see someone who says that my back hurts, and I also can trace a line going all the way down to my foot, but it doesn't feel necessarily like burning or numb or tingling, does that change your diagnosis at all, or not really?
It could be sometimes somatic referred pain could go further than we should, when further that we could think. It's not only it stop at the knee, and it's somatic referred pain. If it goes below the knee, it's radicular pain. Not always. We have to be aware of this. It could be a bit further. So it could be a somatic referred pain, which goes a little bit lower. This kind of things, this neurofitters, it's typical of neurological pain. If you don't have it, then for me it's not neurological. It's not the nerve which is an issue.
Mm-hmm.
No.
Okay. So what is somatic referred pain?
You have a tissue, like a facet, for example. So the facet is not a tissue, but you have tissues around the facet joint. There is a nociception linked to it who goes into the spinal cord. When you have an irritation of this area in the spinal cord, it connects with the same areas where the leg could connect. And the brain doesn't make the difference between both of them. It's like there is the central point in the spinal cord. So it thinks that the pain in the facet or in the leg is the same, actually. It's not a point, it's like an area which is connected in the spinal cord. The best example is probably the heart infarct. When the patient would have pain in the arm, the heart is not in the hand, in the arm, but
Right.
it's the same area connected in the spinal
That's a
cord.
great. That's a really, really great analogy, and I think that somatic referred pain, how that occurs when it's related to the low back, is perhaps one of the most common reasons why people think that they might have sciatica, or why a clinician diagnosed them with sciatica when in fact they didn't. So I think it's really
Indeed.
important to keep that in mind.
Indeed, but you need those neuro features to confirm or to have more likelihood that it's a neurological issue, and then you have to go a little bit further with some physical assessment for example, the straight leg raise that you could perform, touching the nerve, rubbing the nerve to see if it's inflamed. You won't see if it's inflamed, but it could be painful. When you touch your nerves, it's not painful. A nerve is not painful, but when you touch it and it's painful, then it goes in the direction of an inflammation of the nerve. So if you stress the nerve, like pulling or compressing, and if it reacts to this, then you have more likelihood it's a nerve issue with the neurofeatures you had before during your history taking.
For sure. Yeah. So for all those clinicians who maybe just learned about somatic referred pain and they do a straight leg raise and it's not positive and you can't reproduce any nerve pain, don't just throw your hands up in the air and say, well, these tests aren't positive, but it must still be sciatica based off of how you're presenting. There's other explanations, right?
Exactly.
Yeah.
Because we want to believe Eddie, we want to believe what we do think we want to believe. I don't know how to say precisely, but we are sometimes so much
Attached.
attached, obsessed to it's a sciatica. I'm sure it's a sciatica. That if you're sure it is, then it's gonna be a sciatica, but it's not.
Yeah. It's it's always good to remember how complicated biology can be, and just remembering how little we know and that there's always more to learn. And there's likely hundreds of diagnoses that exist out there that we haven't discovered yet as well.
Yeah, of course, of course.
Will, is there anything else that you want to add to this discussion? Any final points about back pain?
About back pain, I won't say no, but I want to talk about our job, our work generally. We do a fantastic job. We share so much with people. We are intimate with people. They want to tell us things that they wouldn't tell at home, for example, or with someone else. I would say, for example, with a psychologist. This is this kind of relation which is different. We are not a psychologist, but they feel they could say anything with us. And compassion is very important. We have to be close for the patient. We have to be interested. We have to be genuine with the patient. We do a fantastic job. Enjoy every moment. Every moment is richful, and don't make something simple more complicated. Back pain is not so simple in kind of way. It's complex, but we can make it a little bit more simple, taking few things and have those lines that we have, guidelines that we want to follow with the patient and stick to it. Don't go in all those directions where it's not needed. Bring more complexity to something that is not needed.
I
I
think
hope it was
that's
clear.
that was very clear, and I think that's an amazing point to end off. So thank you. I really appreciate it. I hope that was sort of a good masterclass for all things back pain, whether it was a clinician or a patient who listened to this. Will, where can people find out more about you? Are there any resources that you have for people, or any places where they could connect with you?
The easiest thing is the Spine Physio on Instagram. I'm reachable on this, and that's it. Actually, at the moment, I
Okay.
didn't. I didn't make any studies, not yet.
Not yet. Okay. All right. Well, thanks again.
Thank you.
Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.